and out of 9 districts, the diabetic center is based at Wellingborough, and we have 9 centers, screening centers in different parts of the country, of the county, and that covers a population of 212,000. The diabetic register, 34,898 are on the diabetic register. Off register are those who are deceased, moved out of the area, or under 12, and they are known in the other program. Now the excluded, medically unfit or opted out are excluded from the annual screening. Suspended, those already in the hospitalized service or digital surveillance, they are suspended, and rest they undergo all the annual digital screening. The program itself, there are 72 GP surgeries, and they are looking after diabetic patients, 34,898. The program itself, we have 9 fixed sites, 3 mobile sites, and managed by the manager and administrative team of 3, fail-safe manager and fail-safe team of 3, screening and grading team of 16, and the hospitalized service is provided by Kettering General Hospital, Northampton General Hospital, with 6 medical retina consultants. The process of screening starts with the invitation. Invitation is done by the admin team, and then screening is done by different screening centers, 9 fixed and 3 mobile. The grading is done at the central grading station. The outcome of the grading is either sent back to the annual screening or to the referral outcome grader. This is the ophthalmologist, and ROG decides whether they need to be seen in digital surveillance or they need to be seen in the hospitalized service. This is the screening station, and this is the central grading station where all the grading is done. Now in UK, feature-based grading and revised classification of grading of diabetic retinopathy is followed by all the graders. The features of R1 is microaneurysms, retinal hemorrhages, venous loop, any exudates in the presence of other non-referable features of diabetic retinopathy, any number of cotton wool spots in the presence of other non-referable features of diabetic retinopathy. Now, HMA is the term where you cannot differentiate whether it is a hemorrhage or microaneurysm. Venous loop and cotton wool spots, which used to be a feature of R2 previously, now they are considered to be feature of R1. The features of R2, venous beading, venous reduplication, very easy to identify. Multiple blot, hemorrhages, and intraretinal microvascular abnormalities. IRMA is considered to be present if IRMA can still be seen on color image as well as red-free image. So that is really important to see on the color image. Multiple blot hemorrhages, very easy to identify. However, in the absence of multiple blot hemorrhages, you have to look for intraretinal microvascular abnormalities, and sometimes it creates a real challenge for the grader. Sometimes it's very, very mild, because if IRMA is present, that becomes R2, and if IRMA is not present, that is still R1. R3 proliferative retinopathies again divided into 2 R3A and R3S. So A is active with new vessels at the disc, new vessels elsewhere, all the features of pre-retinal vitreous hemorrhage, pre-retinal fibrosis, retinal detachment, and S3S we call it when it is stable, S for stable, and photocoagulation marks if they are present. The features of maculopathy, all the known features, exudates within 1 disc diameter of the center of fovea. Now, group of exudates within the macula, this is a new definition which has been now defined, and retinal thickening within 1 disc diameter of center of fovea. Any microaneurysm or hemorrhage within 1 disc diameter of center of fovea only if they're associated with best visual acuity of 612 or less. The definition of group of exudates, how you do it is, you just mark outside margins of the exudates. Now, if it is group of exudates more than half disc diameter, usually refer to the hospital. If it is less than half disc diameter, then do not refer to the hospital. The grading pathway, there are 3 levels of grading: the primary grading, secondary grading, and arbitration grading. The primary grading, disease or no disease. No disease means R0, M0, go to the annual screening. All the R1, M0 go to the secondary. R1, M0, again annual screening. If there is any discrepancy between primary and secondary, that goes to arbitration. And out of primary, again, 10% will go for secondary as a quality assurance. All the R2, R3, M1 and unclassified, they are referred to ROG or Referral Outcome Grader, who is the ophthalmologist. And then it is the decision of the ROG to decide whether they want to send it back to the screening program or to the digital surveillance or to the hospitalized service. So the central role of ROG or ophthalmologist is that whether he decides going to the annual screening or the patient need to be seen in the digital surveillance or SLB, slit lamp biomicroscopy surveillance, mainly for the cataract patients, and digital surveillance. There are two, particularly for M1, with OCT and without OCT. Those patients who need treatment, they are referred to the hospitalized service, R2, R3, active and M1. Once they are treated, they go back to the ROG, and this ROG again then decides whether this needs to be seen in surveillance clinics or it needs to go to the annual screening. So the common pathway is basically a routine annual digital screening module for R0, M0 and R1, M0, digital surveillance module for M1, R3 stable pregnancy R2, and SLB slit lamp biomicroscopic surveillance module for unclassified, particularly the cataract patient, and the hospitalized service R2 treatable M1 and R3A. Pregnancy, usually they are seen in the digital surveillance clinic, first screening during first antenatal clinic visit, again at 28 weeks gestation. If background diabetic retinopathy is found, additional screening is done at 16 to 20 weeks and for at least 6 months postpartum. Quality assurance is really important. And how do we do quality assurance? There is an external quality assurance visit from the national team, and all the annual report is sent back to the national team. So in addition to external quality assurance, there is internal quality assurance. And how do we do? There is the online test and training, which is compulsory for all the graders. They have to do once every month. City and Guilds qualification is a basic qualification before they can start doing the grading. And intergrader agreement is checked regularly. Regular audits are done, and there is a fail-safe mechanism for cohort validation for all the stages of grading and all those patients which are referred to Kettering General Hospital and Northampton General Hospital. So to summarize, the starting point is the cohort identification of the diabetic patients. Once they are identified, invitation process begins. The screening is done at all the peripheral screening sites. The grading process is done at the central grading station. The outcome of this is annual screening, or refer to the ophthalmologist who decides whether this needs to be surveillance in the SLB clinic surveillance or digital surveillance, or this needs to be hospital eye service. Fail-safe process is really important at any stages of the program. IT support is really crucial, and the quality assurance, both external quality assurance and internal quality assurance, is one of the important aspects of the program. My acknowledgements to the diabetic screening program and Northamptonshire Diabetic Eye Screening Program staff and medical retina consultants of Northampton General Hospital and Kettering General Hospital. You can get quite a lot of information on this www.diabeticeyescreening.nhs.uk. Thank you very much.
Thank you, Dr. Satish.